report from QSE, please.
So this report is providing an overview of matters that we've identified at the Quality and Safety Committee that should be brought to the board's attention, and I'm pleased to say it must be working because we've discussed quite a number of issues today. However, our meeting on the 8th January, we wish to alert the board to the Perinatal Committee. We have discussed this, but not actually one of the points that we bring out here, which is that we alert the board to the single point of access maternity triage system, which is due to launch in April 26th, and which is dependent on the recruitment of newly qualified midwives and the approval of the case to support change in the obstetric workforce implications. While overall performance remained positive, the triage process continued to require attention to ensure timely assessment and prioritisation of women presenting with unscheduled pregnancy-related concerns. The committee received assurance from the continuing development of the Perinatal Committee report. I think the conversation that we had before that gives us an underpinning assurance that we are moving in the right direction. That there is that one element of looking at the recruitment of the moving on then to the mental health transformation programme. Concerns were raised regarding the 94 open serious incidents, which Liz has already referred to, including the 47 cases breaching the 120-day investigation target. We have an average of 12 new incidents arising each month. This level of backlog and delay continues to present a material risk to the Health Board. The committee agreed that the board must be made aware of this position and should receive an update on the work being led by this to restructure staffing and processes in order to improve the timeliness and quality of serious incident investigations, with the ambition to significantly reduce, if not close, by the end of March this year. The further alert is to the governance structure that's covering the oversight and risk assessment process, the Your Next Patient, bed closure and clinically optimised patients reduction plan. The anticipated report was not presented to our committee due to miscommunication on dates. The paper will be presented at the next board meeting. The committee highlighted the ongoing unresolved risks and emphasised the need for clearer evidence that risk assessments and safeguards were being applied consistently. The next committee meeting, to be held on the 5th of February, will receive a deep dive report covering the following areas: plan to close surge beds in Morriston and the timeline, model of care for the patients in Singleton and how this is being managed, plan to reduce the risks of blocking fire doors, oversight of the Your Next Patients, risk assessing areas and patients process. There's quite a lot of work in there that we need to take forward. The next alert was to the health and safety deep dive, including the estates and capital report. Significant failures were identified in respiratory protective equipment, with only 4 of 13 powered respirators operational, highlighting the immediate staff safety risks and revealing wider weaknesses in the routine equipment governance, maintenance and fault reporting processes that require board attention. The committee were concerned with the fact that we did not seem to have timely management of machinery that is going out of use. So we did want board to be alerted to the governance on an oversight capacity. Health and safety deep dive, including the estates and capital report. There were risks highlighted regarding the limited reporting of injuries, diseases and dangerous occurrences regulations. 19 reported altogether, 5 were in time, 14 late. Training capacity impacted due to limited resources. However, that training has been delayed somewhat. That the capacity in lack of training has been delayed somewhat in that there's a new package being developed and delivered to some 479 staff, with implications for organisational compliance and staff safety. We had an incoming referral from Workforce and OD Committee, which was regarding the Minor Injuries Unit report on staff feeling unsafe, security and overall patient safety. We were asked to look at this for oversight and follow up on patient safety concerns. Serious concerns were raised regarding staff safety, environmental risks within the Minor Injuries Unit, and gaps in security capability, including the inability to lock down the department, alongside a rising trend in violence and aggression. These risks are foreseeable and significant, requiring immediate senior level attention to ensure robust safeguards, strengthened governance oversight, and coordinated engagement with security and policing partners to protect both our staff and patients. The committee therefore requested that the current risk score of 16 be revisited. In terms of assurance, the committee is assuring the board on the perinatal committee. The committee was assured that the Perinatal Service Board report provided a comprehensive and robust overview of current performance and quality standards. The report demonstrated that the service was functioning effectively, with no aspects of care identified as negative outliers. This has reflected strong governance, adherence to clinical standards, and a continued commitment to patient safety and improvement. I think we would agree with that assurance, having had the conversation had earlier. The committee would wish to advise the board on the Quality and Safety Group report, the Internal Audit Report of Control Drug Governance, which was November 2022. It was highlighted that a further internal audit was to be undertaken during the final quarter of this year to address the delayed response to closing down all matters highlighted in that original 2022 report, which the committee were quite disappointed with. Quality and Safety Group report, the end of life care. It was stressed that the board should be informed that resources have not yet been identified to support the do not attempt cardiopulmonary resuscitation activity, which requires urgent attention to provide patients and families with the appropriate levels of care. Quality and Safety Group report, it was emphasised that the board should be made aware of the reopening of the Caswell Clinic, ensuring understanding of the development and its implications for service provision. And I know Deb has sent a note around about that for us. Mental Health Transformation Programme, all quality and safety priority areas now have clearly defined actions and timelines in place, demonstrating strengthened governance and improved oversight of delivery. There was, however, noted a lack of cohesion across the work streams, which will be addressed by the programme board. So in terms of the review of the risks, the committee will keep the board updated on any developments regarding risks in relation to the above matters. There was no identified sharing of learning, and there was an action to be considered by board, which was brought out of the discussion around services to HMP. And initially we talked about the committee seeking guidance from the board on defining the scope of services provided to HMP Park, which is not our service area as such. However, we were highlighting the recurring concerns about resourcing and operational impact that patients from Park going into a minor injuries unit are creating.
Thank you, Julie, and thank you for that very rigorous and robust report there from QSC. If we can take the alerts, Liz, has there been a slight change now?
Yeah, so we met at the very beginning of January, and as we've just reported through the perinatal improvement programme, the position on triage has changed. So we were looking to go alone on triage. It's now very clear and very strongly suggested that we will have an all Wales triage service, and therefore that recruitment would not be required in the same way as it was if we were providing it for ourselves for a 24/7 triage line. That literally has happened since we had QNS.
Thank you. Thank you. So we will be sticking with the 24/7 line coming in February for the moment until we know what Welsh Government intends to do.
And we're manning that from within resource and understanding if there are any gaps, etc. We monitor and measure that. But the outputs and the monitoring tell us that women are able to access. It'll be better when we get the one line up in February, and we'll monitor their triage time.
And as when you pick up on the open incidents and perhaps weave in complaints management as well, given these are issues with delays, responses, etc.
Yes, and we are currently bringing together our investigations and our complaints and issues and concerns into one team. What's evident or has become evident is that each of the service groups manages in very different ways. So we're now standardising that process, but to ensure we can reduce the number of open concerns and incidents, and our aim is to do that before the end of March. We've redeployed some corporate resource, both from quality and safety and the corporate nursing teams, into those units to give them the support that they need. So for the first time in the last 2 weeks, we are starting to see a reduction in our open complaints. We have also changed the way in which we respond when a complaint comes in. So we make contact with the individual, we ask what their concerns are. Quite often we can resolve in a timely way. That has seen the response times for complaints within the 30-day time frame being achieved for the first time for some time. There's a lot to do, but we have got a clear task group, really, if you like, to get these incidents and complaints closed.
And there are new targets, aren't there, for listening to people?
There are. So listening to people comes in the 1st of April. We want to clear our backlog because the approach in listening to people is a much more open, compassionate approach, and it does always start with a conversation rather than a letter or an email. So that's what we're preparing for. We've got a steering group with all of the service groups, but we will standardise our processes through that.
And Jean, QSE will be tracking and overseeing closure of the backlog, both for incidents and complaints. So thank you for that. And then your next patient and the report to QSE, I think we'll cover this, won't we, as part of our discussions on actions. Is it? We covered, we covered that?
And the paper's going back to QNSC in February.
So there'll be that paper in February, Jean, but I'm certain there'll be other actions from our discussions this afternoon as well. But Darren, there are 2 matters there for you on health and safety.
Yes, thank you, Chair. So we've changed the way we report into Quality and Safety Committee to provide greater transparency, which is welcome. These 2 issues very different. One was around an audit we did of the equipment. That showed that was the units were actually fine. It was the batteries in the backup that were the issue. So those 9 units were out of commission. The total cost of re-providing those units is £9,000. So I've asked the teams to get those and feed that into the theatre audit process where we're having the discussions about the improvements there. So I'll keep an eye on that and make sure that they report back, which clarifies that that's done. On the Rideau one, as Jean kindly reported, there has been an issue with timeliness. We've already reached out and trained 479 people at the time of writing this report, which was a few weeks ago. And we'll also continue to cascade the training necessary to the health and safety operation group. So the actions are proportionate to the need there. But in terms of the new reporting to committee, we'll be able to see traction on those and whether they are making a difference later.
Thank you, Darren. Jean, okay with that?
Yes, with that one. If I could just come back to
why the next patient or what?
No, I wanted to move on.
Oh, I want to move on because we've got the next one, the MIU one. Yeah, because we've also got that coming through from workforce as well. Yeah. So who's going to pick this one up?
I give some of the actions from that, Chair. So it's a very comprehensive update from Kevin, who joined from a minor injuries unit. There were some issues that we've got to explore further as to the patient groups that attend minor injuries unit, the suitability of the staff there. But there are some immediate actions we agreed to pick up around the safety of staff in the unit. So board will recall when we had the queries from our emergency department, we purchased staff cameras for the staff to wear. So we are looking to extend that into minor injuries unit staff as well. So the ED management team are looking at that, so they're under the same group management. And then the one point raised by Gina was around patients presented to minor injuries unit from Park Prison. We'll be liaising with Park Prison and ask them to make sure that if they need emergency support that isn't available through POW, which should be their unit of choice, that if they go to Morriston, not to the minor injuries unit, because it's not, even if the injury is suitable for minor injuries unit, normally these prisoners are accompanied by a significant member of team, and it's too small for them to be accommodated safely there. So we'll be picking that up directly with prison authorities.
So that's good, because it should be POW.
It should be POW, absolutely.
And just a step, as we know, they can lock down. Just didn't know how to lock down, so they now know how to lock down.
So which committee is going to follow through on this then, to lead the actions?
We will further report to the next workforce committee, is my understanding, because obviously there were staffing issues as well that were particularly relevant and were mentioned, and particularly the training and the time for the staff to do their, whatever they have to do in terms of their ongoing training log.
If I can just respond to that bit, Chair. So we will pick that up with them to make sure that there's equity with departments on how they access training and particularly mandatory training, etc. We do need to be mindful we invested a significant additional resource into minor injuries unit. And now the request is for additionality again. So we will be reviewing that. We'll be scrutinising that with some detail to make sure that we know what's needed in there. We don't think we need additional in there at the moment.
Thank you. But Rena, what form can be the lead?
Sure.
On. Okay. So, and Jean, we will obviously take advice and assurance in USC. Well, so shall we move on then now to the next section, which is the here and now, delivery, and Deb, are you starting this or are we starting? Darren?
We've agreed the running order, just going to say.
Yeah.
And there's no.
Fine. And are you emceeing then? Is this your final chance to MC?
I will endeavour to MC.
Most of the levels in the escalation report are covered in the slides anyway, aren't they? So should we go to the slide? So we go from the order of the slide, I think that makes more sense, Chair, otherwise we're a bit risk of repeating ourselves.
Okay.
Okay, so I'll scroll straight to slides. So the first area we can cover on are the escalation levels, and they're all covered in some detail within the slide pack. And I think the initial one is with on the slide, second slide there gives us an update on our current performance levels, Chair, across all of the metrics. So we've got our targeted intervention areas, which haven't changed, unfortunately. So despite some significant improvements in the delivery of those areas, we still remain in targeted intervention for cancer, UEC, HCAIs, finance, strategy planning, and MAPNEO. We can see that in the column on the performance level, we've got the December performance where it's available. For cancer, that's November. Just to give us a little bit of context of where we are with the cancer performance, and we'll pick up further on. We have actually achieved the de-escalation criteria. So in July, August, and September, we achieved, currently you can see it in this slide, 61, 61 and 60% performance, and the target is 60% on 3 successive months. Board will be aware that we always do a resubmission 3 months later. That performance has now improved to 64% for July, 64% for August, and 62% for September. So I did query with Welsh Government officials yesterday on IQPD whether that will mean we will now be de-escalated. Appreciating the performance has dipped since then, but that's not part of the formal escalation. October, we reported 56%. That has already improved to 57%. September is low at 52%. Just worth noting that the number of patients treated in September was significantly lower than previous months. So we're trying to get underneath as to why November sticks out. We know the main issue relating to our lateness in submissions and the amount of benefit we get from that second submission level is around our pathology availability results. So we always report the worst case scenario, Chair. So if we still outstanding results, unless we are sure that that patient doesn't have cancer, we include them in as a breach against the target. So some of those patients then drop out because they are no longer considered in the cancer cohort, and some of them we bring in and we actually treated them in line, but we didn't report them because we didn't know whether they were cancer or not. So that's why it varies so significantly. UEC, you can see that even though there are still some reds in show, and if we look further into the pack, you'll see the comparative performance between December in 2024 and December 25. So even though December and January have been really busy, tight months for us, the difference in the performance delivery is significant still. So our recovery will be better and we'll recover back to where we were pre-December. So for example, I've just written a couple of notes here on that one. Our December performance against 1 hour handover performance, we had more than 600 ambulances delayed more than an hour in December 24. That reduced to 379 in December 25, despite December being a really busy month for us. And for 45 minutes, it was 700 in December 24 against 400 in December 25. So even though it's been tight and it's been really busy, we are still seeing some positive delivery of the performance in there. We alluded previously that we were in BCI during January, so we went into it very quickly at the beginning, first week back in January. We came out of it very quickly, we recovered really well, just over a 24-hour period. Unfortunately, the week after, we had a prolonged period of intense demand and really high acuity and lack of flow out as a probably mainstay of how slow the market recovers after the Christmas period. It's worth noting we weren't the only health boards. There were 4 health boards in Wales in BCI at the same time. I don't think I've ever seen that. And we came out of it more quickly than others, and we've sustained our performance. So we are really conscious of the dip in performance, but we are also confident that we will regroup there. Richard, do you want to pick up HCAIs?
Yes, will do. Thank you very much. So a couple of things to report. That the two things I was going to mention. So progress against the those key infections through which we're monitoring TI, but also what the IPC challenge has largely been in the last few weeks and months. So the challenge that we faced around COVID, flu, and particularly norovirus on our wards operationally, and the numbers as well as some ongoing issues, C. difficile. What's been particularly interesting with those 5 key infections that are measured as part of our TI, so C. difficile, Staph aureus, E. coli, Pseudomonas, and Klebsiella, is the progress that's been made that, Jean, we will see in the way that the templates and the data are reported through QNS, but maybe not in this format. And for QNS members will remember at last meeting, I was reflecting on how progress had been made in Singleton and Neath Talbot in particular, with less progress at Morriston, which reflected some of the underlying issues, particularly around C. difficile, in terms of bed occupancy, overcrowding. I've had some additional analysis since then, and to give you a sense of that, this is what we presented at our quarterly meeting with Welsh Government yesterday. And when you split the sites out, so we set our own internal target for reduction of C. diff, as well as having a target set for targeted intervention. Against our own internal target, when you look at the same reporting period last year, Neath Talbot Hospital is 55% down on the number of C. diff infections. Singleton is 48% down, and Morriston is 17% down, with an overall health board rate of 17%. So while we're not hitting those targets for targeted intervention, there's good evidence across all our sites that progress is being made in C. difficile. On some of those other areas, so Staph aureus bacteremia as an example, last month was the 5th consecutive month where hospital onset cases were below our average for the previous 12 months, with a downward moving trajectory. And similarly for E. coli, we narrowly missed out on 5 consecutive months from E. coli because there was a slight blip upwards. But I think there's cause for optimism in all of those areas, that the work we've been doing that has been described through Quality Safety Committee, that we take it forward with the IP&C group, C. diff goal command, has got traction. Might not yet be at the level that we need it to be to de-escalate from targeted intervention. Progress has been made.
Thanks, Richard. Chair, if that's okay, I think we had a good wraparound on maternity and neonates earlier, so I don't think we need to revisit that. Finance we've got on the agenda next. I'm assuming we'll cover our 4 bases there. I mean, your planning is inextricably linked to the finance plan, so I don't think there's anything you want to add into that space. So we'll go on to the enhanced monitoring area, so level 3. So we've still got CAMS and planned care under enhanced monitoring. You can see there CAMS is now delivering all of the three criteria. So we've gone back up to the 70%, which was the one area where we dipped, if we recall, from autumn last year. That has now recovered. That will recover further, so we are still anticipating further improvement in that area, but we are green in those spaces. Plant care, we are still green in the areas that we have been previously. You'll see a slight drop in the performance there, particularly around the diagnostic elements against achieving the 8-week target. That was and is totally predictable based on the additional outpatient work we've been doing to deliver the Cabinet Secretary's commitment about waiting list reductions. We highlighted that to Welsh Government at the time because we didn't have a diagnostic problem. As soon as we start seeing the additional outpatient work, we will see an increase in the patients breaching what is in essence an 8-week target. We have had additional funding through to address the additional capacity needed in there. It's just taken a little while to get that up and online for us. The one area that board is familiar with has been a pressure point for us is endoscopy. We'll recall that we had some additional funding from Welsh Government to put an additional endoscopy unit on the Morriston site. We have had significant difficulties with that unit being commissioned and remaining commissioned. So it's had to close for 2 different periods, one for 2 weeks, one for a few days before that due to water ingress in the unit. And we lost 2 days this week because they had a power outage on it. So the power is back in at the moment, but we're not sure how much of that lost capacity we're going to be able to make up. So I'm in constant contact with Welsh Government officials on what can be done in that space. We know there's a unit that's currently sited in Royal Glamorgan site being monitored by Cwmtaf Morgannwg. Cardiff is using that at the moment, but it is available for the last 2 weeks of March. So we're exploring whether we can piggyback on that contract and get 2 weeks capacity back in. So we're keeping a really close eye on that. At the moment, clearance of the 8-week target by the end of March is really tight for us. So we're working on the trajectories. It's still early days against that target. We will be doing our utmost to deliver it, but we will improve significantly. There's around 6,000 breaches at the moment. Currently, the plan gets us down just below 1,000 of that.
I'm just going to ask Deb, with the contract with CTM, is it all the same contract to make it easier, or is it we've got to work?
No, but it's on the framework, so we are linking in, and I know Cardiff has piggybacked on the Cwmtaf
Yeah.
contract, so I'm assuming we should be able to as well. It's the logistics again, the patients booked and the reporting,
And
etc.
presumably any clawback for companies delivering for us not actually being able to deliver.
Yeah, there's a I think it's a 2% clawback on there, which is not that significant for us, unfortunately, but we were doing our best, and we'll also be flagging through NHS performance and information how difficult this company has been to work with, so it will impact on what they can do in Wales going forward. It's been an absolute disaster for us through no fault of our own. It's fair to say the teams and the estates team in particular have worked really hard with the company to get that unit up and running. Other than that, as we noted,
Nicola wants to come in.
oh, sorry, Cassie.
Sorry, it wasn't quite on that point.
Right.
No, so you'll carry on.
Do you want to come back at the end then? Okay. Sorry, Deb.
Just to slap it up on plant care. So again, we are still in within our plan to deliver 104 at year end and maintain the 52 weeks performance at year end. And you can see there the other metrics and some of the additional work that we've done through the additional money coming through Welsh Government. I'll include that probably at the next report, or even to performance and provisions. You can see the actual overall improvement in our waiting list positions as a result of how we've used that funding. So it's all very positive.
Thank you. Nicola, do come in.
Thank you, Chair, thank you, Deb. I wanted to pick up on the stroke, because I think the November data is quite alarming, so I was just wondering what we're doing in that space.
Yeah, certainly, Nicola. So I made some notes on the stroke performance here. I'm not sure why we've only got November in, because we should be reporting December in that position, but I've had a quick look at the most recent week for us. And some of the measures that we put in here, it's only the 4 really crude measures, and you'll be aware, admission to the stroke unit's always been problematic for us. It is improving slightly, not where we need that to be at the moment. The CT scan within 20 minutes is the new target. So previously it was a CT scan within an hour. That is generally only feasible if the patient comes by an ambulance, because that's when it's flagged, it's a stroke attendant, so they go direct to the CT scan and get the CT scan immediately. And I've looked at what happened last week for us, and we had 10 strokes presented or reported under the stroke measure last week. Only 3 of those came via ambulance, so out of the 10, 7 of them self-presented. 2 of those who presented didn't present as stroke, so they were very non-specific criteria for coming in. The one was flagged as a stroke. None of them were thrombolyzed, unfortunately. 2 were referred for thrombectomy, and both of those patients were accepted. Unfortunately, both were out of the window for thrombolysis one due to the presentation and one due to the late diagnosis. So we are focusing a lot on how we evaluate the stroke and make sure we're doing the right things in the right space. But some of the measures are very subjective in terms of the patient presentation, how they come through and what the presentation for those is. So obviously, the bleeds will never go through for the thrombolysis or thrombectomy. So it's how do we give probably a more rounded evaluation of what the stroke pathway is doing for us rather than just the hard and fast measures.
Yeah, I think that would be really welcome, Deb, because this is one where time is really critical, isn't it, in terms of outcomes for our patients. So I think that a good look at what we know works well in terms of pathway, and of course it's also relevant about how quickly people get to the front door in the first place. Yeah. So if you just take the thrombectomy issue, which is a discussion that we're having at JCC, broadly speaking, we should be aiming about 10% of our patients getting to thrombectomy, and they either go to Bristol or Cardiff. But if you lose the window because they've not got to us in the first instance, so actually reviewing the pathways and understanding what was the delay is really important. And we've been having a conversation in JCC about access to both units and how that's working through in terms of that opportunity of intervening and the radical difference that can make for those individuals who are eligible. So yeah, I would really welcome that. Emma, with the new Chief Executive of the Ambulance Trust, would be really keen to look at that with us, so to understand the consequences of any delay in the community. And there's really good, I can't remember the names of there's 2 things, isn't there? There's one where there's imaging out in the community to give us image, so reducing mimics and understanding who is definitely a genuine stroke. But there's also the connect from the WAST into a clinician to get fast track in. RED doesn't really lend itself to fast tracking because we don't have a CT, for example, in the unit, and it takes some time. But I do think there might be some opportunities when we know it's a stroke coming through, how you get them into the place they need to first off as part of our pathway. So that would be really welcome.
And just on the thrombolysis rate, just for the note, Chair, we do very well in the percentage of patients thrombolysed compared to other stroke units in Wales. And where we refer a significant proportion of those for thrombectomy, but the acceptance rate is very low. So as I said, those 2, actually, we were fortunate both were accepted. That's not regularly the case.
Benji.
Yeah, and performance of finance obviously looks at IPR. We have been very concerned about certain performance measures that remain consistently poor over time. Stroke is obviously one of those, and we had a report on stroke in December. You've seen some improvement in things like the way they move from acute into rehab,
Yeah,
and motion system. But one of the things we alerted on our report that we're alerting on really is the absence of 24/7 stroke consultant cover, and units with a similar demand of hours across Wales already have that in place, but we don't, and that was one of the things that we did alert on.
And that's been the case for
been in our plan. So 2 years ago, we committed to implementing, I think it was 2 additional posts we needed to get that 24/7 cover in place. And unfortunately, the funding hasn't been available for us to do that at the moment. So it is feasible, we could do it, and it will have a positive impact, particularly on the thrombolysis rate. Not so the thrombectomy rates, because that's not our core, but certainly our thrombolysis rates will probably improve with 24/7 cover.
presumably, Marie, when we come to look at the plan and choices, I mean, given strokes are so important to us, we will be seeing that piece, won't we? And then how much is currently spent on stroke services? Because this goes back to Jean's point a while ago. We need to break down what we're budgeted for, what we're spending, what's the difference, what we're going to do about it. But of course, we haven't done that this year. We've substituted for what we've been doing with the lights. But how will it help us in 2027 to determine how much money we should put into stroke service?
So I think this is one that we would need to pick up under our revised programme governance. So it would probably sit within our UEC programme board.
And Jean, was that your question, or is it a different question? Because I know you would be very keen to try and make sure we understand what we're spending, what we're budgeted for, what we're spending, what the difference is, what we should do. So was that your, sorry, was that your question, or was it something different?
It was one of the questions, yes, because I still don't feel we've got that visibility.
Pleasure. And just on that point, I think if we do a direct comparison of just purely on stroke,
Yeah.
without that 24/7 cover, we probably compare less favourably because we don't have that medical cover in place. If we look at the full pathway, there are efficiencies we could make in the pathway if we configure the pathway in a different way. So we've talked about bringing the reablement beds that are currently in Neath Talbot back into the Morriston footprint. The medical model in Neath Talbot is very expensive because it's a standalone unit and we've got medics over there covering patients. But technically, if we change that configuration, we wouldn't need that cover. That may give us an option of reinvesting that, some of that money at least, to cover off what we need for sustainable stroke cover then at Morriston.
Thank you. Brilliant.
So this is a really interesting case in point. So when you look at some of the work that we'll be taking forward through the clinical services strategic planning, stroke services is one of those examples where the resource and the workforce and model we currently have will not allow us to meet all the stroke standards. We simply don't have the critical mass and the workforce. So that's one of those services where our solution lies in a regional approach at the very sharp end of stroke. So we can, and the team here have done enormous work and bridged the gap with what's available locally. But we know that there is a strong drive nationally and from a Welsh perspective to look at how do we develop a more regional approach to the delivery of acute stroke services, because that's the only way we can make it a 24/7 service.
So can I just ask then on that?
Yeah.
As Howells are taking specific meetings on their clinical services plan, and we're talking about this on a regional basis, and we would be in the region with them. Do their plans take this into account?
So I think their first step in their clinical services plan is to do what we've already done, which is look at what do we have locally and how do we strengthen and improve that local offer within existing resources. There is a requirement to step that next level up and look at how do we do this on a regional footprint. There are clearly challenges around developing that plan, but it has to be in the direction of travel.
And can we, do you want to come back on that before I bring Jean back in?
Not on that. I've got other areas that I'll raise, but
So Jean, you come back in then, I'll return to back.
I can come back on that because that's really pleasing to hear it. When we look at the, Pat said earlier, when we're presented with these figures, we seem to be getting either no traction or we're going backwards, as in endoscopy, and Deb's told us why that's happening, because I'll still hold you to the point that she said by the end of October we would have had that sorted, but that was October last year. So when we look at performance and we're not delivering, taking your point about the way in which we look at things, my concern is if we're not getting traction, someone needs to look outside the box, because if we're doing what we've always done, we'll always get what we've always got. And I think that's where we're at this stage. That's why we're not making any improvement, because we're not looking outside the box. And then I had one last question, but it's not aligned to that.
You ask the question, then I come back to Pat, go, okay, and the PSP matter.
You mentioned, Deb, the water ingress in Tŷ Meddwl.
No, in the endoscopy unit, that was Jane.
Yeah.
So the
Tŷ Meddwl.
in-health unit, as I mentioned, the water ingress.
Then here from the notes, it was page 19, Tŷ Meddwl. Water ingress on the roof. So what, and my question was, what were the mitigations that we had in place to manage that, and where were we at with it?
You answer.
Tŷ Meddwl is the campus building.
Is it on tap? Is it tap?
We
Going Doolally tap.
Okay.
I'm sure.
It's the campus building. We're in active discussion with the landlord at the moment, on the way in which the landlord's meeting us. We've had similar issues to this in what I can say.
Can I just read what it says so that
Okay.
I can ensure for myself I'm not going round the twist? The Swansea-based clinical space, Team Ethel, has been closed until April 26 due to water ingress requiring roof replacement.
Where is that, Jean? Sorry.
Page 19.
That in the narrative report.
It's after CAMS part 18.
Yeah.
That is the
But
kind of-
that's not what I was referring to when I said about water ingress. Apologies. That was the endoscopy unit that's been put on site in Morriston.
No, I was asking the question about Team Ethel.
So, yeah, so my answer is relevant to Team Ethel and the activities with the landlord present, given the condition of the building.
So Pat, would you like to come back then to PSC matters?
Yeah, a couple of other areas which we haven't really covered but remain very static in kind of performance is neurodevelopmental diagnosis and intervention less than 26 weeks. We still have 600 children waiting over 52 weeks, which has a huge impact on their development and schooling. I know we had an insourcing tender, which was funded from additional monies from Welsh Government, wasn't it? But they've gone through that process and no contract has been awarded, so that's worrying. And the other area really was neck of fever, prompt surgery, and more recently NICE compliant surgery, which are well below UK and Wales averages. So just on those two areas, really.
Definitely. I'll pick up the ND bit first. So we picked this up in IQPD yesterday as well. So you'll be aware, last financial year, we had circa £900,000 of additional funding to address the children's ND weights, which we used that money very well. And we got our waiting list down to the lowest in Wales. As a result of that, we had very little additional funding given to us this year. We had £190,000 allocated to us, which was far lower than any other health board had. Unfortunately, the way we used the money last year, we went out to a tendering exercise and looked at how we use sort of Teams resource, if you like, for therapies for children using companies in England. We maximised the patients that we had who were suitable for that sort of assessment during that period. So the ones that we're left with now are the ones that weren't suitable for that type of contract. We went back out to tender to look at something different and nobody tendered the additional contract. We're currently back out through a different framework at the moment. And yesterday we were at a 10-day call-off period. And I'm not sure what that is at the moment, but I think we found a solution. We just got to wait to make 10 days to make sure there's no challenge to that contract, probably a single quota tender. So once we get that through, then we've got 22 of the one assessment and 44 of the other assessment that we can use that funding for. But we've still got a similar challenge that we've got going forward is that we've got a resource issue within our ND service, which is similar across Wales. We now have our clinical lead, the ND service, has left the service. That affords us an opportunity to modernise the service with the team we've got in place. So the directorate are looking at how we work with other health boards who make different changes to us and how we change some of that model. It's a national problem, so it isn't unique to us, and we will clear. I think it's down to the 2-year waits for us this year, but it remains a challenge. And one of the areas where we all of the services across Wales are trying to work with is how do we engage differently with education so that the patients who come into the secondary care services are those who need the expertise of secondary care services, not the diagnosis bit, to give them the certificate to go into education and get the needs that they need through education. So I think we had that update when we had in board development, didn't we? We had Dr. Peter Donnelly updated us. So that's what we're looking at for all of those services, to make sure we can make the best resource, make best use of the resource we've got in secondary care, because we're not at the moment due to the high demand that could have been managed in a different way.
Do you want to come in on that point?
I think on that point is we need to have very clear scrutiny on it. I think so. Can we just give me some time to think about it from a this perspective? Because I
It's a
think
regular report through to Performance and Finance Committee
just
anyway.
to make sure that we are doing the right thing. Because I was going to have a very similar on neurodiversity, which you've answered. I think on the CAMS, it was around Darren, which was the relationship to the one that we had earlier, which was around the roof. It was about not just what are we doing in terms of repairs, but actually what are we doing in terms of looking at other public sector buildings that we might be able to use alternatively?
So,
Yeah.
we are looking actively at the variety of premises within Swansea City Centre mental health team for number of different services which are dispersed and in suitable kind of accommodation. There's a very specific issue with team member and integrity of the roof. So I've also been put in a little bit of considering that along with the work we're doing to extract ourselves from centre. These work to get lots of services in Swansea City Centre.
But presumably on that, Marie, in terms of our estate and assets, the plan for 26-27 on, that will start to signal what we're going to do in terms of our land and asset base.
So the capital planning team have a detailed schedule of schemes that they are allocating the additional discretionary capital to. What we need to do is make sure that that goes through the appropriate scrutiny as we finalise the priority components of our
So on the
plan.
basis that we've said we're operating on too many sites,
Yeah,
does the plan start to signal how we're going to reduce the
Yeah.
number of sites?
Yeah.
It does.
yeah.
Good, good.
And
Yeah.
John, I wonder, I found the reference it's in the text escalation report before the integrated performance report, so I can see exactly where it's. And notwithstanding what you said, Darren, in relation to this particular building, that wider bit, I do think there's something about if we are losing capacity for these young people, there is something about if there's something urgent we can do to provide an alternative. So that there may not be, but it seems if we're losing 40% of our clinic capacity for a very particular cohort of young people who are waiting, and that would have an impact on their access times. I do wonder whether there is an urgency, as well as the wider things about if there's any alternative at all, recognising it might not be perfect, but things like Singleton, where I think we've got some outpatient space, et cetera. I think we need to look pretty quickly. If it's not going to be fixed until the end of April, that's too long to be not finding an alternative place to run these clinics.
Yeah, that was exactly the reason why I had the question. I don't know, Mira said, are we targeting the urgency part of it, and then what are we looking outside? And then there's a bit about the discussions we've just had, where it's clarity around our clinical services plan and what are the constraints because of the regional approach to the way that we're working. What are we working with commissioning arrangements? What are we working with other health boards? I think it's all about clarity. And then what are we doing in those areas where we've got weaknesses to actually enable these states, because we know it's a huge risk in our risk register, to work more outside the box with our partners on our partnership approach. So I think it's marrying all of that information together.
And hopefully that will come through in our annual planning process. And it might be helpful. And we will make available to all independent members all the papers that go with the meetings of the RJC, the Regional Joint Committee.
Yeah.
So Hazel, if you circulate those to everybody, even though not everyone comes, because there's a breadth of work underway on a regional footprint. So that would be helpful for everyone to see there. And can we remit to you, Anne-Marie, this question of looking for alternative accommodation quickly? Have we just discussed it? Is that fine? Thank you. Darren.
Just an additional comment that we have established a capital management group which sits above all the other parts of capital management at the moment, which are all working very well. That we've spotted that the coordination piece that was just described is probably something we need to be tighter on. That will be the first meeting in a couple of weeks, and then we'll feed into the planning process, and that'll be part of the business of the board.
So then you
Would you like to actually have questions on genetic
Oh, go on, yeah.
I'll reverse those, so apologies. So the two measures you mentioned, so the timeliness for surgery and the NICE compliant, they are inextricably linked. So we know timeliness for surgery is affected by the length of time it takes us to get the patient to the ward, because they won't take them to theatre without there being a bed available. So sometimes the patient could go to theatre if there was a bed, but the bed is the block for us. Our demand for NOS is the second highest in the UK. So the numbers of fractured NOS we get is disproportionate to the rest. We probably need to get underneath that as to why we see so many fractured hips in our population, but we do. It's really huge demand. And when we look at compliant hip surgery, it's the full pathway that they look at as the compliant bit rather than just the surgical element. So it's the timeliness for surgery, it's the rehabilitation, and it's the discharge back to the community, all of which cause some of the delays we've got in all of our pathways, which means why we've not got a patient into the bed in the first place. So if I look at our pathway of care delays at the moment, 11 of those patients are fractured hip patients that are stuck in our system because we can't discharge them back home. Some of them don't go back home as a result of an injury, but those delays are quite significant. Some at Morriston, so 7 of them are at Morriston, so delayed in our orthopedic wards, and 4 of them are in our reablement beds in East Talbot waiting to be discharged. So I think when we start looking at the whole pathways and how we manage the discharges differently, we will then hopefully see a correlating improvement in patients getting to the ward in a timely manner and then get into surgery within that 24-hour period.
Last point of Richard, then we will need to move on. I think to the next. Anybody else, please take them questions outside through Eva. Richard?
Just to add some more information to Deb's answer. So of the 11 KPIs, sorry, of the 8 key KPIs in the National Hip Fracture Database for NOF, Swansea Bay were actually better than the UK average in 5 of the 8. And what's really surprising perhaps is that the admission to a specialist ward, the UK national rate is 10%. We're 1%, we're dreadful. But it's pretty dreadful across the UK in terms of hitting that particular aspect of care. There is some assurance I hope to be taken that, for example, in terms of prompt geriatric, the international average is 89, we're 97%. And we exceed some of the target by similarly by 10% or so. So there's good work wrong, but there are challenges.
Thank you. Thank you very much. A very rich discussion there. We're clearly going to need to reschedule our agenda and allocate more time for this segment of the integrated performance report. So we'll need to be brisk in the other sections because we've got to spend sufficient time on the finance report. So, Darren, are we next on population health?
Yes, we will do.
So Hugo, anything specific, please?
I think the figures are very much similar to what's been previously reported to the board. Some of the data we rely on from Public Health Wales that is indicated as we're in discussion with them to ensure that we have good data flows from them. That's all I'll say. Thank you.
And we'll need to move on swiftly. Quality and safety. Liz,
Yes, let's start. We've already talked about our major issue, which is complaints and incidents. The performance is set out there. We are using a different format in setting that out, so it tells you where we are, what we're doing about it, and when we think it will change. Just wanted to really highlight the positive overall score for patient experience. 85% is the All Wales target. We're at 95. We will be at 90% at the moment, and we were commended for that yesterday. Our IQPD, pressure damage reduction and falls reduction. Some really good work going on, which is utilising in full our improvement methodology. So what's the data telling us? What's driving it? What are we going to do about it? And when will it take?
Do you have anything to add?
I think I covered off the IPC issues in the previous section. My escalation.
So Matt, for digital next, please.
Just 2 points to make on the digital section. So for the first time, we've introduced some metrics around digital enablement, digital maturity. There's further, we need to work on those further over the coming months, but it was just a start of a 10. There's something on discharge summaries, electronic test requesting, etc. So be welcoming feedback and some of those metrics that we've displayed. Key thing to highlight is around the LIMS program, the National LIMS program that, as you know, aims to replace the pathology systems across Wales. The latest meeting we've had with DHCW was yesterday, and we now officially are not going to complete the program by the end of the financial year. It will roll into Q1 of the new financial year, and there are financial implications as we've been reporting via risk to date, but that now is going to come home to roost. The financial implications for our organisation for Q1 are 190k revenue, 180k capital that is unfunded and isn't going to be funded by Welsh Government. I know that with the plan that Darren is working up, we have factored that into that plan, but obviously it's a concerning picture. The 2 areas of concern are blood sciences and blood transfusion. We aim to complete blood sciences by the end of Q1 to reduce any further cost for that. But blood transfusion is more concerning with the work that's left to do on testing. We're the only organisation that use LIMS 1 for blood transfusion. The other organisations have different legacy systems. They have issues of their own as well. but we're the only ones who are relying on some kind of extended contract or support to keep LIMS 1 active beyond the end of Q1. And understanding the finance is an option that's still being worked through for that element of it. But what we do know is Q1 is going to cost all organisations across Wales.
Then you move to workforce, is it? Yeah.
Yes, Mr. Dean.
Yeah.
Thank you.
Yeah, thank you. Just two areas to highlight to the board. One is the performance appraisal development review, which is still sitting at about 73%. That means still a quarter of our workforce haven't had a appraisal in the last year, which I think is really key to the setting the culture and tone of what we expect from individuals and giving them feedback. So we will be taking that forward through the performance meetings with the service groups and corporate areas this month again. The other key bit to talk through is the sickness absence rate, which increased to 8% in December. We have seen some impact from colds, cough and flu in that, but if we remain at 8%, that equates to 1,000 whole-time equivalents each year that we're losing the sickness absence, and therefore it's a significant impact to our variable pay and to our finances. I know that's something that we probably want to pick up in the next financial bit, so expand on what we're doing about it then, if that's okay.
Okay, so we conclude this now. We've obviously considered all the different dimensions of it, but we do need Hazel to take this away and look at the format of this report and make sure we avoid duplication with what we've already heard through AAA reports or earlier in the meeting. Okay, so we just need to streamline this whole approach because we spend a lot of time on operational delivery, as we should, but then we don't spend enough time on the other dimensions of it because we've got other matters that we need to get out. Okay, so we've considered everything. We've acknowledged and identified a raft of actions associated with different specialties and services, which we'll reference in the minutes. So, Darren, we're going to turn to the finance report now. As a signal, this is a pivotal meeting for the board with 2 months left to go of the 25-26 financial year and with 2 non-negotiable targets to achieve: 55.4 million savings, 58.7 million maximum as the year-end position. These are non-negotiable and the board has to receive details and proposals of how the executive proposes to the board that we are going to meet these targets. So this is a really important agenda item this afternoon. So I shall hand over to you to give your report. Then we will take perhaps advice from the Performance and Finance Committee, and then we will open it up more. Darren, over to you.
Thank you very much, Chair. So as you said, the report before us today is the month 9 finance report for the Health Board at the end of December position. But as we're reporting the 29th of January, it's 2 months worth of action after taking point there. Section 3 on page 4 of the report just reminds the board of those 2 key elements, Chair, that's reported formally around the savings and the deficit requirement, the maximum deficit requirement, 25-26. Board members will know that the detailed financial position has already been reported through briefings, formally within the board, and then formally to the Performance and Finance Committee meeting, which was held on Tuesday. In terms of the overall revenue position then for month 9, it's on page 5 on the report, I outlined the position, and the Health Board reported a £3.83 million deficit in month 9, and whilst that's the best month of the year so far, we need to go further for that in a moment. But that takes the cumulative deficit of the Health Board in the year to date, so for the first 9 months of the year, to 55.18 million, and that means we are 11 million off plan at that point in time. We've been around 44 million, we've been delivering the 8.7 million across the year. Clearly that 55.18 million deficit is very close to 58.7 maximum, with 3.5 million away from that, with 3 months worth of financial performance to come into the books, which means we need to run from a rate of 3.8 million a month, which is our best month, down to 1 million per month for the next 3 months. That to change. So we must therefore see at least the £3 million reduction in spend per month for the last 3 months of the year. And this needs to continue into next year as well, which is a fundamental point around the way in which the financial characteristics at the end of this financial year are starting to impact our planning for next financial year. Savings are set out in table C at the bottom of page 6, and that shows the current savings gap in the savings plan for almost 12.6 million. with 42.8 million forecast delivery. And there are actions which we agreed at the December board included in the report, and further actions that the executive is working on, which I'm sure we'll cover in conversation, but I'll touch on. Very importantly, the recurrent element of that plan is only 22 million following scrutiny and challenge in the last week or so with service groups. So there's a 33 million pound risk in the savings plan, which translates from this year into next if we do not act. We can act, and there are things that we can do to make a difference. I referenced the special board, which sat on the 16th of December, and page 7 of the report reminds board members of the core actions there. As I'm not going to go into those in detail, but they're listed for me in the report as things that we said we would do collectively this year. At the bottom of page 7, my report sets out some of the additional actions that could be initiated and will be subject to executive discussion this week. I'm sure again we'll come on to those in conversation. The month-end financial position will be known a week tomorrow, the 6th of February, and that will give a clear indication of traction or otherwise in month 10, and that will require further action, so that not be where we need to be. The areas we are looking at the moment are theatre optimisation, bed configuration, further enhancement of the non-pay controls in place, further variable pay controls, and across this, as Gina's just described, looking to support workforce behaviour and improvement around sickness, absence and availability and some of the cultural aspects. By way of full transparency, at the bottom of page 8, there are a table of one-off mitigations that have arisen through the year. Those one-off opportunistic mitigations could arise by the year end, and I've reported those to a formal monitoring return. Myself and the finance team are currently looking to work through those to firm them up. Some you don't know the exact number until the end of the year anyway. Some will have some certainty on over the coming weeks. But any value that comes from that work cannot be relied upon to allow us to land the year on a provision, and certainly cannot be relied upon in terms of the recurrent position of the board. It would be helpful in helping us mitigate risk at best. We need to get that very quickly across to feel about run rate and savings we need to do. Further analysis of the month 9 position and the cumulative impact of month 9 is set out in the further pages of the report. If I just run through them, some of the aspects of other financial performance per the report. Capital on pages 12 to 14 reports that we will now balance the capital resource level. Obviously, we're paying 40,000 that's weighted. Everything else is on track. And just to perhaps add some substance to the numbers, the Health Board's discretionary plan is 13.8 million, but a total capital spend this year is likely to be over 50 million, which reflects in the national programmes that we're working on, but also the success we've had in pulling forward the money into the system to modernise a digital estate and to address equipment maintenance issues and equipment as well. So there's a lot going on in terms of just managing that through the year end to get that certainty. And the balance sheet details set out in section 5.3, I was going to cover that in any detail, as is the cash position. The board supported the letter for strategic cash support. I was about to update you that I know this week the letters come in today confirming that cash support is in place. And now public payment requirement of achieving over 95% of invoices paid is reported at 96.4%. Risk section report through the year consistently reported on the revenue and capital positions. My assertion at this point is the revenue risk remains at 25. Our proposal is to de-risk capital from 20 to 12, because we've got the resource we require to balance the plan. The residual risk there is that we get everything in before the 31st of March and the supply chains. The summary, Chair, as you've already said, we're at a pivotal point in terms of this year's delivery, and very relative to our action this year and the way in which the next 10 or so working weeks play out. That will set the tone and the basis from which 26-27 will also feature in terms of our financial performance and the scale of challenge that the Health Board faces.
Thank you, Darren. It's very sobering there. Pat, would you like to give the board the advice, please, from PFC?
Yeah, so I'll just go through quite a detailed note really from PFC. So in relation to the current year, 25-26, following discussions with exec colleagues in Performance and Finance on Tuesday, we do now have reduced confidence in relation to achieving the 58.7 million planned deficit in the current year. And the risk level at this point in January remains at 25. In relation to progress on the plans that were presented to board and the Welsh Government on the 16th of December, which was mitigating savings, the variable pay enhanced controls do not appear to be delivering. Early indications in relation to all non-medical variable pay in the first 2 weeks of January is that we are seeing a bounce back to pre-Christmas levels, up to about 550 whole-time equivalents a week. There is no evidence in the whole time equivalents of the necessary reduction in line with that 50% cap that we proposed in December. This is due to very high levels of staff unavailability, in particular sickness levels, as Tina alluded to, plus the need to cover high levels of healthcare support worker vacancies. It's indicating that there is a lack of robust and effective sickness management across the health board, which we're going to need to address really at pace. Further than the closure of surge beds in Morriston following the opening of the new clinically optimised ward in Singleton has not been implemented. This is due to the winter pressures and the ongoing high levels of clinically optimised patients that we see across the system. Pictures in relation to non-paying procurement won't emerge until we fully close month 10. In relation to next year, 26-27, as Darren alluded to, this lack of delivery in relation to the exec-led savings programmes that form part of that September 25 submission to Welsh Government has left the Health Board with a savings shortfall of 33 million in 26-27. We've also got operational run rate pressures that are creating a further carry forward of 50.7 million. A significant element of that is in relation to mental health services, including adult mental health out of county placements, variable pay and CHC. So overall, that has increased the opening deficit position for next year by 48.7 million. And this is on top of, we reflect, we already have a savings target in that year of 44 million that we have to address through new plans, etc. So it's putting us in an extremely challenging position as we move into next year. We did note that the 26-27 planning process is being progressed in a timely way and is far more robust. The plans on a page for that 44 million 26-27 savings are significantly ahead of where they were last year, and these will be subject to more rigorous test and talents moving forward. The approach is more integrated between service, financial and workforce planning as well. It was noted that there are clear plans emerging for utilising nursing staff resource and improving rostering, but these ongoing issues with managing sickness, etc., will undermine those plans if it's left unchecked. So overall, from PFC, the failure to deliver the savings programme has left the Health Board in a very challenging position, as we stated, for 26-27, and radical plans to address that 48.7 million shortfall must be developed at pace moving forward. The lack of progress in relation to the September and December plans has limited the confidence of PFC in the Health Board's ability to deliver the required actions and plan deficits in the current year and moving forward into 26-27. We're particularly concerned with the accountability and ownership across the Health Board in relation to the management of staff sickness and unavailability, the lack of progress in relation to the exec-led savings programmes with such huge implications for next year, the lack of progress and ownership of service group saving targets. We're also very, very keen to understand that the actions that could be taken urgently in reducing the number of clinically optimised patients. I know that's going to be a regional discussions and possibly even a national discussion, because it is an issue that's shared across health boards across Wales. And really an update on the management of those acute mental health out of county placements is going to be important as well. And one of the suggestions we're making really is some kind of meeting with the execs, with the service groups, with the board as a whole, so we can look at the actions and the confidence levels we can take as we move into next year.
Thank you, Pat. On that last point, we will do that on the 26th of February. So thank you for that. But I'll just ask other members of PFC if you want to add before I hand over to Abby. Steve?
I don't think I need to add anything, just to reiterate, the PFC would like to see some quick and radical action, both in respect of meeting the targets for the current year, but also in mitigating the risks carried into the next year that Darren and Pat laid out.
Brina?
I just think in terms of workforce, our focus, particularly coming from here, is this unavailability and the way in which we performance manage our unavailability and sickness within the organisation. And that is going to be key in terms of getting managers on board with the right culture to performance manage that. Angie?
Well, I know you've mentioned or used the word pivotal, Jan, but for us, this is a pivotal moment for us as a board to demonstrate alignment, decisive action and accountability, which has not been delivered thus far. It's a critical governance concern that we must address without delay.
Abby, may I hand over to you,
Yeah.
please?
Thank you, and thank you for your feedback and the challenge we had in Performance and Finance Committee earlier on in the week. So just to take you through, in summary, what we've been doing to further tighten the controls in the delivery of the plan that you have seen previously. And I'll ask each exec to update in terms of where we have got to. So we had an informal discussion, we had a meeting in our informal management meeting, which is every Monday morning. We dedicated the whole of the 2 hours to this, both in year and plan for next year. We then consolidated that in specific decisions and found up in our formal executive meeting, which again on Wednesday was dedicated to this agenda item. And then we had finance and performance. No, we didn't. We had recovery and sustainability board yesterday, which was predominantly focused on the plan for next year in terms of going through in detail the plans on a page and totting up where we've got to in terms of the savings opportunity there. You will know this is really challenging. If it had been easy to deliver, we would be further ahead than where we are. We know we were slower in the beginning of the year to get traction on this. And the support we've had from Deloitte has been really helpful in terms of identifying where the opportunities are and how we transact the opportunities in through our savings. So the headline areas, it came up in a separate agenda item around our beds. We know that we have additional beds to the tune of 130 something open. And we, I'll ask Deb to talk through the plan that we've agreed in relation to coming out of beds that we need to close down and reduce that footprint, and predominantly around making sure that patients are only admitted into an admitting bed if they absolutely need that. Because we have heard things like social admissions where we're kind of like the point of open access and we need to manage that, but also particularly around making sure that patients get home in a really timely way. And that is a challenge. And I know it came up again in previous conversations on other agenda items. In terms of workforce, Tina can just summarise a number of actions in relation to sickness absence. It is a critical issue. There is, and Tina will talk through what we're doing as a general approach and then some specifics in terms of the action we need to take. There is, in addition to that, making sure staff are confident around how they roster staff and do the rotas, because availability is high. Even if we were in a sickness, absence was down at the target levels we need to be aiming for. There's something about how staff are managing their rotas within their teams. If I ask Darren to talk about the non-pay elements, and again, one of the things we need to tighten is how we get visibility and traction on the action. So, you know, waiting with our fingers crossed till the month end, we need to have either confidence coming through service managers and finance business partners and the teams to go, yeah, we feel that it's having impact because we're turning down fewer requests. We're, you know, requests to travel. We're not signing off travel expenses. There has to be intelligence that we can utilise to give us a sense that those things are having traction in the organisation. And then if I ask Deb to talk about the work that we're doing around plan care, there's work on productivity and efficiency, there's work on how we profile the activity to make sure we maintain our commitments in terms of plan care access, but how we ensure any opportunity of profiling patients through as part of that work we can take forward. We're also looking at anything else that we can go at. So there are some service groups that are running better than others in terms of their underlying position. And we're asking them to go further, where there are underspends on budgets and hold those and push those further. And there are areas where we've made good progress and we'd like to push further because we know that against sort of national benchmarking, there may be further opportunities. Again, some of that we'll be bringing forward that will lead us into a good place or a better place for going into next financial year. So things like prescribing, really reviewing high cost drug expenditure and other areas that we might want to target as part of that. Chair, I'm happy to pause there, but if we want to go through each of the themes, I think that probably will be useful in terms of giving you assurance. In terms of totting up the impact that's having, we're working that through, and Darren's team are keeping a tight grip on that. And I guess briefing and updating as we've been doing on a weekly basis in terms of the impact of that. I know we've got a dedicated session with IAMS next week, but my suggestion is we need to have an opportunity of giving feedback on it. So I don't know if we want to start with the beds. On my list, in terms of the notes that came out of our Monday meeting, and we haven't had formal notes from Wednesday yet. But Deb, do you want to talk through what we've got planned? Just before we ask Deb to do that, with all of this, there is risk and impact, and as a board, we need to understand those risks and how leaning into this really hard has impact and consequences. So for us, making sure we're articulating and describing that impact and understanding it. So when we are running through these, we're doing that, and we need to flag to your attention anything that concerns us. But fundamentally, we need to deliver the actions that have been set out. So Deb, do you want to talk about beds?
Yes, certainly. If I talk about the beds and the planned care bed, I think most sensibly what we're saying is our cost base at the moment is including costs that should be borne by other organisations. So if we are not going to pay for some of this work, then somebody else has to. So if we look at some of our contract work, we are delivering services that we've been commissioned for that we're not getting full remuneration on. And in this space, we are providing care for patients in beds who shouldn't be in our beds and should be somewhere else. And again, those costs would be elsewhere. So if we're going to manage within the financial envelope, as Abby said, there's got to be some significant decisions and significant challenges into how we manage through that space. If I talk about the bed bit in the first place, because we've had a good wraparound on how we reduce expenditure in the urgent emergency care system, and about taking out some of the funding that's been badged as investments into that. And given where that funding is at the moment, that would really destabilise the services that we are delivering at the moment. But the significant overspend for us is that in the beds that we've got open, that we wouldn't need to be open if the service was working as it needs to. So as an example, Abby alluded to the number of surge beds we've got open. We've currently got 144 surge beds open. So that's 107 in not on ward designated space, 37 your next patient spaces. And we talked about those earlier on. On top of that, we've got 48 medical outliers. So medical patients who can't get into the medicine wards, so are outlying in other wards. And that doesn't include 44 patients who are waiting in our emergency department or in our assessment units, again, who should be in the downstream wards. So in total, that's almost 190 additional patients that we've got to accommodate. But if we're looking at the pure surge numbers, that's 144. If we look at the clinically optimised position that we've got currently, so we'll all be aware that we've had some success in reducing that. We were an outlier when we started reporting this. I think it was probably a year ago now, Chair, wasn't it? We looked at it. Our numbers were significantly higher than other health boards. So we have brought that down. Currently it's sitting at 173 clinically optimised patients, which is high enough on its own. But when you look at the bed day delays in that is over 7,000 bed days. That's 19 years worth of delays in our hospital beds. It is pretty significant. We met with senior members of the RPB a year ago, and chief execs of the health boards and the local authorities attended that meeting with us. And at that point, we agreed to reduce our clinically optimised patient numbers to 100 by the end of March 26. That remains our goal. If we reduce that down to 100, it gives us the ability to enact the surge reduction plan that we've discussed at the moment. And that surge reduction plan, we're going to go at it in a number of different ways, but predominantly the beds that are costing us the most money in the first instance. And we've got two areas that are costing us around £40,000 a month to staff. So we've got beds in our older persons assessment unit, what we call Purple Bay, that is not staffed in any way. So we are overstaffing in that space. That's costing us £37 a month. Our aim is to close that this week. So at the moment, we're making some good progress as we recover from our business continuity programme. And we will close that on plan tomorrow, if we can empty it. And then the next area is a AMU surge, which is 17 beds in that area, and that costs us again same amount of money, so circa £40,000 a month. And we've given a commitment to close that area by the 13th of February. So that's our stretch plan for reducing those two. Alongside that, we've given a commitment to close a further ward area. Ward E in Morriston is where we're looking, but that's going to be worked through to make sure we pick absolutely the right patients. And they are all clinically optimized patients on that ward. So as we empty that ward, we can reduce the staffing element in that, and obviously we can have an empty ward in Morriston, which we desperately need from our IPC space as well. Some of the release of the funding in these areas, we go into further beds, Chair, is more difficult because we know we're overstaffed on some of our ward areas. So even if we close the beds in some of that area, we'll be left with a residual overstaffing element. We'll work through that as we go through the further plans. And then the next area is to look at another ward area in the first month of 2026-27. So we're still working through the detail of those plans. The first two areas, we are quite confident that we can enact that by the deadline. And then we will be working on the rest of it from a bed reduction perspective. Now, it may sound counterintuitive, given that we've just come out of a significant period of business continuity, and it is, and it's going to stretch us. And we've been very clear that the only way we can close those is by reducing those clinically optimized patient numbers. What we can't allow is for those beds to make sure that the ambulance is back up outside an emergency department and the ED goes back to being extremely pressured as it was prior to June last year. So if we do those things hand in hand, we are confident we can make those necessary bed reductions.
So the question about my next patient, your next patient,
Your next
mine, is that model, we need to protect that model. It's really good model that a nice flow through the day, because what we do know is you see the peaks and troughs, and it enables us to do what they're designed to do, to take your patient up through the from the assessment unit if they needed admission, on the basis that someone actually can move into that bed who's due to go home. So we do need to, that's part of the continuous flow model that we had in place, and we've lost a bit of grip on that. So we need that back. We need to firm up the plan. So we got clear plan on the first two elements. We need the firmed up plan on the second element in the way that Deb has described. But our articulation of that and the description with the all of the service groups were in the room yesterday, confirmed that this was an appropriate action for us to take, an action that they were behind. So I think it's the detail, and we need to support the clinical teams to facilitate those conversations about patients going home. So particularly the cohort of patients that are halfway ones, these are patients who we have a shared understanding they may need some domiciliary care to go at home, but they need to go home to have the assessment, if that's the right thing to do, because we know it will look very different. So we need to make sure there's appropriate support if people need a bit of bridging through third sector or whatever it is over the period before we can get the local authority assessment in place. But that's what we've got to focus on as part of this work.
I'll just ask on 100 beds by March 2026. All partners signed up to that as well, didn't they? Through the Care Action Committee arrangements, subsequent arrangements, they are all signatories to that.
So we committed to, at the beginning of the year through the RPB, reducing our clinically optimised patients to a target level of 100. We recognise that the additional actions that we're going to have to take to try and accelerate achievements to that number is going to be very difficult. We need to make sure that we do that in collaboration with all partners, not just our local authority colleagues, but also with third sector and with our patients and families as well. So it's a step change.
How will that be organised through the RPB then?
So we have we have a communities and older persons board which oversees the kind of 6 goals programme which this falls within, and we will need to use that forum to communicate and ensure that we accelerate some of the planning work that's going to be necessary to hit this target.
There's a weekly meeting as well, isn't there, with the leads to...
There's a weekly meeting with the directors of social services, but this is wider than just local authorities. This needs to involve all of our community stakeholders as part of this exercise. Yeah.
Yeah, so just on that bit, so there will be work for us to do in this space as well. So our behaviours and our adoption of some of the stretched actions we need to take need to change within our wards as well. So we've talked a lot at board and finance performance committee in particular around D2RA, so the discharge to recover and assess. That's where we need to go in this space. It's a tried and tested model, and it means those assessments are undertaken in the patient's home. Now, whether that's home is where they came in from as their own private home, or whether it's if they came in through a care home, they go back to that care home to be assessed for any additional needs. At the moment, the decision that they don't and they need care is made in hospital, in conjunction with hospital staff and social workers. So we've got to change that narrative, say the patient's ready to go, they don't need medical care anymore. They now need to be assessed of ongoing need, and that needs to happen at home. So we need our partners to pick up those patients when we enact D2RA. We also need our staff to make sure they are acting in the best interests of the patient, which is not to keep them in hospital, which we do at the moment, because the whole process then changes. So there's actions for us to take, I think, in the health board to make sure that we deliver it in that way as well as partners.
Can I just ask on this? We shouldn't be in this position now. We should have been on this the whole year. So can I just ask, what's got in the way of getting on this the whole year? Because we shouldn't be in this position at the end of January.
And I think it's probably a combination of both, of all parties not enacting what we agreed to enact. So us not pushing on D2RA, the domiciliary care not being available, the assessments not being available, which has resulted in the system logging up. So we all know how our behaviours need to change and how the system needs to react. And it's which lever do we pull on first to make it happen.
Then Nuria.
That was
Sorry,
exactly.
Marie, did you want to add to that?
Yes, I did, yeah. So I think the fact that this is, as Pat alluded, not a local issue, this is a national issue. There has been a much improved position in our region. Having said that, it was a very low baseline from which we started. So that should be acknowledged. It is a multifactorial issue. We tend to get very focused on the kind of social services pathways, and there are undoubtedly improvements that we can make, and there's local learning that we can apply there. It is both a cultural, a process, and a system re-engineering challenge. I think the complexities around discharging patients back to their home or back to their place of residence in the community has many, many challenges, both from a clinical and from a social and from a kind of family perspective. So it's not, I just want to emphasize, there isn't a quick fix, which is why we get so far and then it comes back again. I think there are 2 or 3 golden opportunities that we need to jump on and try and amplify. One of those is almost certainly a health board owned opportunity. One of them is about how we work faster and better with some of our colleagues in social services, and others are about how we use some of our local systems in the hospital probably more effectively. So I think it is multifactorial, and we just need to make sure that we are, all of us, taking responsibility for delivering those improvements at pace.
I've got Nuria, then Rena, then I come to you, because this is not new. And that is what we really need to understand as a board. How do we find ourselves here now? So Nuria, then Rena.
So for me, there's a bit about that. I totally get the behaviours side. I get also that there's a bit about understanding the risks better in terms of the whole system and what is the residual risk that we're actually needing to tackle that we are not clear on from our perspective as well as from the stakeholders that are involved. And then there's a bit about governance and escalation and how does that happen? What are actually the levers that we've got? I think that we need clarity on those risks. And what is it that in terms of our performance, if we hold ourselves to account, what is it that we can hold others to account on? And I've never had, in the time that I sat in this health board, I've never had that clarity. So I think there's a bit about not just the process, but actually what wraps around.
We can't hold partners to account.
No.
We have to agree with them. So Rena.
Yeah, I just feel as if I'm getting a bit of deja vu here from in that I feel we've been here before. We've said we're going to hold people to account and get, if you like, the other mechanisms in place to allow people to be discharged for assessment. But it's not worked because I'm not convinced anyway, and that's what I'm worried about now, is the resource there in the community in whatever shape or form? You've got an older person in bed in hospital. You want to send them out to their own home, say. The family are really concerned, and is it there for them? And how are we going to get that level of assurance that there is going to be something around them in terms of doing that DR, whatever we call it, discharge to assess, and that there are people that will hold them in a the state they're in when they come out of hospital. Otherwise, we'll be getting them back in. Reality being, whilst we wait to do that assessment, sort out the package. And I think we're going to get a lot of resistance from families to accepting that their older person is coming out. So I just don't quite see how it's going to be different this time compared to how it's been in the past.
Got Hugo, Deb, and I'm going to turn to Abby because we've got to close this bit to get on to the next piece of action.
This is a simple point that I think all of us know, but I think it's worth remembering is that for people who are clinically optimized, hospital is not a safe place to be. And I think that that's just really important as a driver for seeking to address clinically optimized patients.
Yeah, before I come back to Abby.
Yeah, and Rena, that has been the debate, and that's why where we are. And rather than address the capacity gap and take the risk, as a health board, we've held on to the patients. And it's not the right thing to do for the patient because they do decondition very quickly in hospital, and some of them will never go home as a result of that. But it is a challenge for us. And sometimes when you plug a gap that should be filled somewhere else, then that gap will never get filled because there's no incentive to fill it because we're plugging it quite nicely using money that we don't have, quite frankly. So I think we've got to work with partners how we give some assurance that the patient will be safe. There are some options of how we can look at that. So we've got community resource that perhaps we could look at a different way for a short period of time to allow a decent time for assessments to be taken, etc. So we'll work up through the detail of that, and of course we work closely with partners in that space to keep the patient as safe as we can do. But if they should be at home with domiciliary care, they should be at home with domiciliary care, not in a very expensive hospital bed and not doing very well. Family dynamics are a huge problem for us in that space. We know that we get a lot of pushback from families on the wards now with patients, sometimes because they want to take their family members home and they can't because the care's not there, and sometimes because they're nervous about taking the family member home without the care. So we get a lot of debate in that space. So we've got to support our staff to do the right thing by the patient and work with the partners to make sure that is being provided. As we said, we can't hold them to account. We can just work with them, hopefully, to get the patient in the right place and reduce our spend alongside keeping our patients safe as well. Just to give the system a little bit of assurance, Chair. So we have done some evaluation as to where we are in the space outside of the clinically optimised patients, and our length of stay for patients who do not become a delayed package of care is very much in the mix. So it's 4.1 days for emergency medical admissions, and that's very much in the pack nationally in Wales and on a UK basis. And our admission rates per 1,000 population, again, is very much in the mix. So if we were outside of those parameters, I'd be very concerned that actually we're not managing the patients in the right way. We're admitting too many and we're keeping them too long before we look to discharge them. Those numbers give us some assurance. But when we look at the clinically optimised patients on their own, the length of stay for those patients in December last year was 28.9 days. And that's on average for those patients. So you can see why it's a problem for the patient from a deconditioning perspective and why it takes up so much of our resource. But we are keeping an eye on what we should be delivering in the health element of that, what we should be delivering in partnership, and what should be our responsibility of others to deliver.
Abby, what is it that the executive wants the board to agree with?
So I think there's two things, Chair. I think there is the agreement to the explicit actions to take the beds down in the way that we've described and hold our nerve in terms of the other system changes that colleagues have talked about. So we need to push both. So there's the real immediate term to get the cost of these beds out of the system, notwithstanding what Deb said in relation to certainly ward, one of the wards being staff. but we can redistribute those staff and bring down agency spend or bank spend in other areas, so we can utilise that staff, as we're doing with the streamlines, for example. So we need your support to push ahead. I think we've already got that because it was a plan as part of Your Next Patient anyway, to take down a ward. So we really need to accelerate it. There is a medical leadership job, there's a nursing on the ward leadership job, but there is a therapies role to make sure that we are keeping people ready to go. So, and we need to pick up, Jan, you and I are meeting with the leader and the chief exec. I'm meeting with the chief execs of local authorities on Friday next week, where we will reiterate this. And Richard's working on some communications about Hugo's point that it's safer to be at home. I think there are some other things we will look at trialing very quickly. Things like phoning within 24 hours of somebody going home to check they're okay, like we do with mental health, have a visit after 72 hours. We might even want to think about, could any of our community health staff, in addition to virtual wards where we're stepping patients down into virtual wards, that is a virtual ward, so they are still under our clinical care. These are patients who don't need to remain under our clinical care. So Jan, if we're seeking, I guess, your support for continuing to push very specifically on taking these beds out, and that being the communication out from the board that this is the action we're going to take, with Deb holding the ring on the specifics in terms of the plan. And then we need to continue to push. We will always have some. We're never going to get down to zero, and we recognise that. It's about how we manage those patients effectively and when they come into the system.
Thank you. One last point, just to address Rena's point about patients bouncing back in. One of the other key partners for us in this space will be Welsh Ambulance Service. Okay, so we've got a single point of access, and any ambulance conveyance should be having a conversation with our clinical teams in that single point of access before conveyance happens. So if it is a non-medical admission or conveyance, we direct that patient to the right space. So if they need us, they come. If they don't, we direct them at source rather than the water ambulance, and we'll manage it with partners in that space as well.
So just to confirm on that then, so this week you think Deb would take down the older persons union?
Yes. Purple Bay.
Purple Bay, 13th of February, the AMU
surge. Yeah.
First month of 26-27, Ward E, then possibly another ward during 26-27.
Yeah.
We are working on the 100 by March 26, and we will be communicating that formally to our partners. Abby and I, when we meet with the leaders and chief execs, we will be reaffirming that. And Marie, we need to do it formally through the RPB mechanisms. And Abby and I will write to the Cabinet Secretary and Jacqueline Totterville to say, this is what the Health Board is doing. Okay. They're planned care then.
Planned care. Okay, so where we are with planned care at the moment, so we are keeping our commitment to deliver the 104-week target at year end, which we've obviously committed to all year and delivered for a big part of that year as well for us, and we continue to do that. So that remains a red line for us by breaching that. And we've got, just by way of numbers, 613 patients left in the cohort for this March to deliver that. And some of them, so the biggest number is in orthopaedics, so that will take us until the end of March to deliver that. And we still need some additionality by way of theatre capacity to deliver the volume that's in orthopaedics. But our commitment in terms of making the savings in that space is that we will take all other additionality out of the system, because some of our specialties will deliver within their core. On top of that, we're going to be focusing quite firmly on our productivity and efficiency to make sure our core capacity is being used in the best possible way. I talked about orthopaedics then, to be fair to orthopaedics, they're amongst the highest users of our theatres and have the best utilisation. They're doing some really good work in that, so we're on the right track in there. But ENT and orthopaedics are two of our challenge specialists, but numbers that we've got to continue to do a little bit of additionality in that space. But we're committing to do that. Going forward then next year, Chair, we're a little bit uncertain of what the picture looks like into 26-27. So the Health Board receives some significant additional funding to continue to deliver 104 weeks this year. We're hearing at the moment that that funding may not be available in 26-27. If it's not available, then continuing to deliver 104 weeks will become a challenge for us anyway. And looking at the numbers, we will stop delivering for orthopedics in April, and some of the other specialties come on during the first 6 months of the year. And that will largely be out of our hands because we won't have the additional resource to do that. But we will manage the numbers in a better way because we will be increasing our usage of our core capacity. So therefore, we'll deliver more in what we're already spending. The word of caution in that going into next year, obviously, is currently the additionality that we do is covered fully with additional funding from Welsh Government. If we improve our core usage, then some of the non-pay costs will then come into our core budget, which will increase our overhead. So it's going to have to be a very fine balance going into 26-27, some of which is unknown at the moment. But just to give the board assurance, we will understand our demand numbers going in. We will be very closely with Deloitte on upper quartile delivery against theatre utilisation and productivity, it looks like, and we will be meeting with each of the directors regularly to make sure they are delivering it. Those meetings start next week, so Hannah Parsons, who's my Assistant Director of Plant Care, and I are meeting with all of the directorates and the Associate Medical Directors and the Clinical Directors next week to illustrate where they are currently with their productivity, efficiency and utilisation and what we expect them to be delivering going forward. We have choices we can make in some of this space. I think this year they are a little bit limited in what we turn off due to where we are so close to year end. There is only 8 weeks left between now and the end of March, and theatre scheduling starts week 6. So we've got a small window of opportunity if we want to do anything different. The target we set ourselves from a thematic work with Deloitte, we will deliver on this year.
John, or that's quite. So what you're asking the board for then is confirmation that we won't reach the 104, but we will take out additionality when we can manage on the core, and then of course 26-27 that's going to be very challenging for all health boards.
Just one word, sorry Chair, I should have brought this in. So there is some additionality that we're doing as part of the cabinet secretary's commitment, which is catchbacks predominantly. If you remember, there was a commitment to so that will be additionality that's not 104, but it's fully covered from a cost perspective.
Everyone happy with that? So shall we, Jean, did you want to come in?
I'm confused. Doesn't take a lot to confuse me, you know that, Deb. But when you're talking about, we've got 613, was it? Patients left to manage.
Yep.
To year end before the new financial year kicks in. We've got theatre inefficiencies, which you've talked about. So for me, there's a thing about a more holistic approach to this. Is if we have funding now, how many of those 613 do you believe we can clear? And have we looked at improving the productivity and utilisation of theatre in order to get more through?
Yes, on both of those, Jean. So we will clear all 613. So that is the commitment, and we will do that in all of them. We could do more, but if we do more, then obviously we incur more costs this year by way of non-pay as well as improving our theatre utilisation. So for orthopaedics, for example, our theatre utilisation is around 85%, which is what the target is for orthopaedics. We could push some of them to do more, but every time we do a bit more, that costs us a bit more as well this year.
That's the bit I don't understand. If we've cleared them all, and forgive me for being so naive here, but if we've cleared them all, why is the funding for those patients over that 104 week hitting us so badly? Because we will have cleared them.
We'll clear them this year. So this side of, by the end of March, we'll have cleared them, and the funding is with them to clear those 613. If we go beyond that, then we don't have the funding to clear those ones.
The allocation formula for next year, Jean, is nothing like as generous enough to enable us to carry on at the rate we've been going.
Right.
Darren, did you want to come in there?
Just to add some numbers to it. So the current planned care allocation for Wales this year, 170 million. For a few bits and bobs on top of that. For next year, the indications are that at best that will be 20. Given the outlook for next year at the moment, there is no mechanism to release that. So we're working on the basis it will be 0. And those are the numbers nationally.
And all health boards would be.
I'm just going to say, Chair, for assurance, our performance is still the best against 104, so we've delivered it consistently and the numbers are pretty good. if we are not delivering, then no other health board will be delivering either. Which is not a great place to be because we need, we want patients in Wales to be treated, but we won't be on our own in not delivering that target.
Yeah, just reflecting on next year, I mean, that funding is staggering, that drop, but the theatre utilisation is going to be absolutely critical, isn't it? And recognising we've got much better information, a lot of good work's been done, but it's still really concerning, the low levels, especially in Neath Talbot, etc. So that's going to be absolutely critical work, isn't it, for lifting that theatre utilisation.
And we may have to take choices next year to take some theatre capacity out if we improve our theatre utilisation, because there's always a risk if you keep those theatres in, you'll do better in the theatre utilisation, therefore you'll do more work, which is going to cost you more money. So if we're going to keep it in a financial envelope, then we've got to keep a close eye on what we need to do, what we can afford to do, and how we do it in the best way.
Yeah, I think I was just going to make reference to this will be one of the, well, there'll be several plans on a page in relation to this for next year. So there is really good housekeeping to make sure that none of our patients who are in the not procedures that we wouldn't normally undertake. We're checking about looking at that in relation to the criteria in our patients. Are our clinicians applying the criteria really, really carefully? But there are a whole suite of other things around criteria for health pathways, right the way through the pathway in terms of referrals, referral management, managing patients through in a timely way. And so if they do need an outpatient procedure, day case, or an inpatient procedure, there's the optimizing patients, there's the rapid recovery post-surgery. All of those elements we need to have in place so that we can maximise the patient flow, utilise that. Must be one of our most expensive resources alongside critical care. And we need to make sure that we are flat out. There may be consequences in terms of some questions around, do we actually end up overstaffed in some areas for the activity and demand that we've got? That will be a difficult thing that we need to work through. When you look at our increase in workforce, and that will be some difficult conversation. We know we're going to have to go there anyway in terms of fragile surfaces. We know cardiac surgery. We know cardiac surgery is coming out, although we're doing more for the South East region at the moment, where it's planned. But there'll be other examples where changing way we deliver services means that we do step down surgical activity in the way that we're currently doing it. We need to reflect on that as part of our plan going forward. So I think, Deb, you gave the example of things like criteria required to be put on our list that may only be applied to orthopaedics at the moment. We need to make sure it's consistently applied across all of our services. So there are a number of things in the planned care improvement programme that will give us choices about a monetary opportunity or a capacity opportunity, and we will then need to work through and have a conversation here about which do we want to take up that board conversation.
We do a very focused amount of capacity planning for next year as well, based on what's in a consultant job plan. So our surgeons, if they're scheduled to do 3 lists a week, how many weeks are they delivering 3 lists a week for us on, and making sure that they are correlated specifically. Each of them will have their own balanced scorecard of what they are delivering as a specialty and what individual consultants are delivering, and the expectation when you go into that job plan review. So we're firming up on a lot of that area, and our business intelligence team will be very busy.
I know this is a flight of fantasy, Chair, but that is a typical area where generative AI could be really, really useful.
Yeah, definitely, absolutely. Thank you. We'll note that. No, yeah,
Just from an accounting perspective, before we move on, Darren, this is probably the last chance I get to ask you this question, and you've probably heard it before, but it's an important question that I need on the record. A significant part of our plan to reach our focus position involves accounting adjustments, So I've asked previously, but for the record, to get assurances around the risks of any novel accounting treatments and to the lower certification of our accounts, is there anything you need to alert us on?
There's nothing I need to alert you on. Those are end of year proper activities that will satisfy a condition.
should we move to workforce?
Yep. So the conversation we've had at execs is around sickness absence and the impact of variable pay. For me, sickness absence are looking is to have a healthier Swansea Bay, and 72% of our staff live within our boundaries, if not in our communities. So to me, it's really important that we get the health of our workforce and use them to make any contact count with our communities as well. What we do know is that where we've focused on long-term sickness absence cases, we have seen an improvement and reduction in those. But however, we're seeing an increase in short-term sickness absence cases. So we need to continue that management of the long term, which we will do. But the actions that we've agreed as exec is to do an open letter to the workforce, obviously running that by staff side and other key stakeholders before it's issued, which really sets out what is costing the organisation and patient care. And we put those figures into the open letter. And me as an individual member of staff, I've got an obligation to manage my attendance, to be proactive in my own health and well-being, and to make sure I comply with a management attendance policy. If I meet a trigger, I should be expected to be called in to a meeting with my line manager. And if I continue to not fulfil my attendance, I escalated through 3 stages and then exited from the organisation because I'm not fulfilling my contract of employment. At the moment, we've got no central recording of those escalation meetings. That's something that we're going to work on to make sure we've got the oversight and people are complying with those formal stages. We've also looked, and we've only got 10 line managers that are on performance management at the moment. Sickness absence management is a part of that, not the only reason for that capability. But there's clearly improvement to be made around making sure people are being held to account for attendance and line managers being held to account to do what they need to do in the policy. So they've got the open letter, and the other bit that we've agreed is to stand up weekly meetings with each of the service groups and corporate areas that are over target, where we'll be looking at the top areas of absence within their areas of responsibility, making sure that we've got the corrective action logged, or we put support in place where we need to. That's the main actions that we've agreed, and happy to take any questions or comments on those.
You haven't got any quantum savings then identified additionally for workforce?
So for this year, the quantum savings part, Darren, correct me if I'm wrong on this, that we've agreed to take out the current vacancies as well. That won't affect the financial position overall, but what will put us in a better position for next year. There's that bit that we're doing around vacancies. We're not going to be taken out for where the staffing levels are covered by the Nursing Act, because we have to maintain safer staffing levels, and those posts will need to be covered. And we'll take out all the other vacancies, and then there'll be a need for a business case if people want to add them back in. That makes sense. So that's what we're doing for this year.
Sorry, Tina, I meant additional quantum savings from these additional.
So this is part of the 50% reduction in variable pay bits. It's not additional bits. This is trying to get to realise where we are for the last 3 months. Does that make sense?
That makes sense. So getting traction on what we've already said.
Yeah, sorry.
Richard, then Jean.
Yeah, as well as the grip and control element that Tina has outlined very articulately, we've basically been focusing as well on a couple of really good examples where we can show that staff have already started tackling the issue of sickness, and they've made some substantial progress. So Liz has flagged up a couple of examples. I met with the teams last night, so one in Singleton and one in Neath Talbot Hospital. One of the teams has reduced sickness from 21% down to about 6%. So they now have gone about that in very different ways, because it's been based on engagement. It's made a very real difference. But as was discussed last night, it was about savings, but it was also about patient experience and staff experience as well. So there were benefits in the round there. So the way that we're going to focus on this now is to highlight those as examples, to try and motivate others to find their own way of tackling these issues and to make the similar progress. And that will be a focal point for the top 100 meeting next week.
That's good to hear. You know, and basically people do it themselves. There's more ownership, there's more responsibility, isn't there? And they're actually motivated to deliver it and then sustain it. So thank you, Richard, and for that positive point there. Do we move on to rostering competence then?
May I just ask, is there a gap in the information that we are retrieving from HR business partners into central HR? Because in my view, if I'm responsible for a service group, I will know how many people I've got on disciplinary or absence or whatever. So is there a gap in capturing that information to enable you to do?
So it's held locally rather than centrally. So there's a bit of an exercise to do to put some of that information on our central system. So like the return to work interview dates and the formal sickness absence review meetings. But each of the service groups have got that information when they've done undertaken audits.
So forgive me, because then that's intimating we have another black hole, isn't it? Because you know what you know. Local service managers know, or business partners know what they know. And there's a black hole, because surely if we're having regular meetings with direct reports, that information can be either cascaded down or passed up. So are we not having those meetings with those staff in order to understand what the figures look like?
Yes, so there's each of the service groups do audits on their sickness absence and have their records, but it's held locally. So we don't record on the central ESR system the two meetings that we're meant to have. So the back to work interview and when they're escalated onto the formal process. So I can't give you an accurate information to board because it's all manual local records. So you're right in there being a gap, which we're working on to address.
And I think, Jean, we can take an action on what data set should we have at organisation level across all aspects of workforce so that we can undertake organisation-wide reviews, comparisons, etc. So we can take an action on that. Pat?
Yeah, just very quickly, in the past, working in organisations where they've turned around sickness, the absolute critical thing is that data. It's being able to say the sickness level in every unit and having it almost on league table kind of status.
We've got that on the intranet that's there with the highlight, and we've got the heat map. But what I haven't got is the compliance data with policy. That's
and that is critical, isn't it? The central HR can go and challenge an area and say, why aren't they on compliance? It'd be very challenging. Is you need that data at your fingertips, don't you? And that's where
there's there, but I'm not wanting to present it yet because of the data quality of it. There's some work to do around it.
I mean, this comes back to systematising really good quality data right across our systems. And I think ESR is a really clunky system. We're getting a new one. I can't remember what the timeline is that. We're not going to be a pilot for that or an early adopter for it. But I know that if that was working really well and was really efficient for staff, we would be able to get our hands on all that information. And I think it's variable use, Tina, in terms of all of its elements of utilisation. And that is part of the problem in terms of how you cascade the information up. But I think Tina's talked about how we get a handle on that and how we make sure, as a previous conversation about how we're strengthening our approach to performance management accountability is having those conversations all the way up. I think Richard's point is really important. The policy is there to help and support and to enable staff to make have the right conversations with staff and feel like they want to be in work and a good place to be. We know the difference between a well-run ward and a well-run team and those where actually maybe the managers are struggling in terms of their capability. So the other programmes that Steve has talked about, that we need to embed proper management and leadership, the brilliant basics that are there, we can track how many people are utilising and accessing those kind of things. So it's building all of those things up as well as the very specific targeted action that we need to take as well.
Darren, non-pay?
So there are three elements to the non-paid chair. One is just the management of spend from this year into next. We identified £350,000 that we can defer into next year. We're looking for another 350. That's active with the business partners at the moment. The second element is procurement savings. We set ourselves a target of £4 million anyway in year, so that wouldn't affect the bottom line. The stretch is another 1.1. I think I've got the 1.1. I think I may have more than that, but I'm just triangulating that to make sure it's not already in people's positions. But we're over 5 million in terms of procurement delivery. Just don't want to double count it, so I'm urging caution. I haven't worked that through. The third element then is around discretionary non-pay spend in year and into next year. We've issued through the Making Every campaign and through the Parity and the Recovery and Sustainability Board a series of expectations around things like study leave, travel expenses, whereby essentially what you need around non-clinical supplies. as Abby said, we are trying to find a way to monitor that in live time rather than wait for the ledger to roll, and colleagues in Deloitte are helping me with that. But what we're working up separately, and I've got the flowchart here in front of me, is Oracle is our purchasing system. A system control in Oracle prevents ordering things unless they're flagged for a specific clinical or urgent reason. And then that flows into a panel. And that panel makes an immediate decision not to negate the clinical need. And then there's enough flow of workflow from there that will allow a decision to be made on whether those requests will go through or not. So rather than relying specifically on the cascade of human behaviour change, we're going to bake in an Oracle system-based management system to do that. That will not deal with travel expenses. That's a separate system. We're just trying to think about how we might handle that as well. So we have further group and control into the end of the year. That may well, and I'll know this next week because the work is live at the moment, a complete stoppage from the categories of spend that aren't clinical. We just need to bring that proposal to the executive team to make sure that's appropriate.
Comments on that one? No, thank you, Darren. Quite comprehensive, isn't it, really? Adding to what we've already got. So the only other things we had then, because we covered the plan and care, opportunistic underspends at service group level, and then we've covered the accounting tree. So that's it in terms of the list. So we've got bed reductions as specified, with associated actions, particularly with partnering with government. We've got implementation of the 104 report because we'll take action not to exceed that. Further restrictions of non-pay spend that Darren's just outlined. And we've got workforce related measures, which basically are to sort of enhance the possibility of delivery of the savings we've already identified. We've taken an action around the data need at organisation level and board level to assist us. And we know that we can't quantify these savings at the minute, but hopefully next week we will.
Yeah, we have to.
And when next week will that be available?
Ben work in particular at the end of the week and we'll share it at the end of the week as well.
End of next week.
A dedicated exec session on Monday to discuss all aspects of the plan, the traction specifically in this year.
Okay.
Next week, and we'll have Monday 10 on the way.
Thank you.
So we can do combined briefing.
Thank you. But Pat, can I ask you, can you perhaps schedule in a PSC week of, not next week, the week after? If the information is available at the end of next week, can you schedule a PSC just for board oversight purposes? And then we do have a meeting on the 17th of February on a single issue if we need to, depending on what month 10 tells us, and reference to what we may need to do in 11 and 12 in the report, Aaron. We may have to add a finance item on. Is that okay? Yeah, Andrew?
Just really a point of clarity. I've added up some of the savings as we got along, just to see if I'm in the right ballpark really. I make it £2 million at best from what's been said for this remaining 2 months. Am I madly out?
You're a little under, but the thing that is as yet unquantified is that impact on variable pay. And that's what we need to nail in terms of the reduction and all the other aspects. But first thing we'll be able to say.
Yeah, but the variable pay, we're already relying on that, are we? Or is there additional variable pay bit?
What we're trying to do is get the 3 million run rate reduction nailed in 3 months. So 9 to 12 probably is what the need is. Variable pay will be a feature, procurement will be a feature, and then one-off mitigations. We won't get to the year end with one single aspect of those. We need those to work together.
Yeah, no, okay.
And the measures that we've taken are on top of what we have already done, because clearly we haven't delivered what we wanted to. One of those is clearly around rostering and rostering differently, but also working with, and I've got some of my team working in with those that are creating rosters for future, as well as clinics of scrutiny now. We're doing scrutiny clinics on rostering, on sickness absence, on, there's a huge amount going in intensively now. But But for me, it's the rosters we're creating to manage variable pay, which doesn't give anybody access other than through that roster and how we deploy that.
But it seems to me that that is the crunch issue, isn't it? For us getting to the end of the year rather than some of these other measures.
And knowing what's influenceable in that.
Yeah.
What I will say is we meet on a weekly basis as a nursing and midwifery workforce board, myself and the service group nurse directors with support from HR and from finance. We're very clear. The data that we've now built tells us where we need to focus. That's where we'll put our focus intensely.
So we can take us to the recommendations then. We will have a 5-minute, 10-minute tea break after this, and then we'll get Deutrin again. But just to take us to the recommendations. So we obviously acknowledge where we were when we started the year in terms of our financial plan, but we have to accept the non-negotiable targets, 55.4 million, 58.7 million, and we reiterated our commitment to deliver those at the November board. So we have to accept those. We've commented on the financial performance, but really we've expressed our significant concern rather than just consider and comment. We've supported and agreed a range of additional actions which we set out to ensure that we can get to those year-end targets. And clearly there are still outstanding actions from the December the 16th board, which we really emphasise the focus has to continue on delivery against these. Pat, if you can just pull PSC together for that item of overseeing the quantum of these additional savings and the implications when Darren has them ready. And then if need be, we will add an item to the 17th of December of February board on any further actions we may need to take. So I covered everything. Okay, let's have a 10-minute break and thank you all. That was really, really intense conversation, but we clearly needed to have that. Thank you. 10 minutes and we'll be back.